Hello, everybody, and welcome to the IJLCD Winter Lecture for 2025. Wherever you are joining us around the world, we're very delighted to have you with us. It's going to be a wonderful couple of hours together while we hear about what makes language interventions work, exploring the active ingredients. Just a couple of housekeeping things that we need to talk you through to make sure that you're comfortable and that you are able to access the tools that are available to you. So we have Justina, who is going to be hosting us tonight, and on your screen, she will come up as the RCSLT host. She's going to be on hand, but not visible on your screen, but available throughout the entire lecture for any technical queries or concerns that you have. And you'll be able to get in touch with Justina via the chat button on your screen. In addition to that, we're going to be having a Q&A facility that is running throughout the entire lecture. We will have a separate section at the end for the questions, but if questions come up that you have for the speakers throughout the lecture, we're going to ask you to type your questions into the Q&A. So access the Q&A button and type your questions in there. And then the other piece of housekeeping, just to let you know, is that the event is being recorded. And of course, that means it's going to be available for people on the RCSLT website after the event has finished, along with the slides. But it does mean that if you've got any concerns, you just need to know that it is being recorded as the evening or as the event occurs. My apologies for saying evening. I'm joining you from New Zealand, where it's 10 o'clock at night. And of course, it's 9 a.m. in the morning in the UK, and clearly at different times around the world for other people who are joining us. On our next slide, just some other housekeeping information to let you know. As I mentioned, there will be a Q&A session immediately after the presentation. And what that means is that many of you will have already written your questions in as part of your registration process. You will have indicated your questions, and we will answer them at the end. We've themed all of the questions because there were a lot of questions. Some of them will be addressed throughout the presentation from our presenters, but others of them, of course, we will address specifically in the Q&A session at the end. Following the lecture, there will be an evaluation or a post-lecture evaluation form that we would like you to complete, and that will be available to you via the QR code. Of course, we would like people to complete the evaluation form in the time that is set aside for it today. But if not, then we'd like you to submit your evaluation as soon as possible after the lecture. And we will include the information from that evaluation to pass on to our lecture presenters today. But also that information will be helpful for us in preparing future lectures and any information or suggestions that you have for how we can improve things in the future. The other piece of very exciting news to pass on or to let you know is that at the beginning of the lecture today, we're going to be presenting the IJLCD 2024 Editors Prize. And Mark Jays, who's one of the associate editors, will be joining immediately after I finish speaking to award the 2024 prize. And one of the things that he will do just before that is explain the process that was undertaken in order to arrive at the selection or the award for the top prize. So I will hand over to Mark and he will speak to that.
Thank you, Claire. Welcome everybody. I'm very excited to share this news about the Editors Prize. So every year we have a prize for a paper that the editors have selected as the best paper for that year. And with my colleague Saloni, we led the editorial team through a robust selection process to select the top article. So there are 8 members of the editorial team, 2 editors-in-chief and 6 associate editors. We asked everybody to select their best, what they felt was their best paper based on the rigor of the paper, the study, its methodology, the quality of the writing in the reporting, and also the clinical significance of the paper. And then we took those 8 papers and we each ranked them in order to select one paper, which came out top overall. And we were particularly interested in the work of early career researchers rather than established researchers. And we were careful to exclude any articles that had been authored or co-authored by current or previous members of the editorial team of IJLCD. So if we move on to the next slide, I can tell you that, thank you, that this, well, the prize for 2024, so of all the papers that were published in 2024 in IJLCD, we selected this paper by Loretta Gasparini and colleagues, Identifying Early Language Predictors, a replication of Gasparini et al. 2023, confirming applicability in a general population cohort. That paper is available open access on the journal website, so I would urge you all to have a look at that if you haven't already. Many congratulations to Loretta and colleagues, and we will be announcing this elsewhere after the lecture. So thank you very much, and I'll hand you back to Claire, I think, or Hannah.
Thank you. Thank you, Mark. Wonderful news. Congratulations to Gasparini and her team. So on behalf of the International Journal of Language and Communication Disorders, Claire McKean and I want to extend a very warm welcome to Professors Pauline Frizelle and Cristina McKean, who are going to deliver our IJLCD Annual Winter Lecture this morning or this evening or whatever time it is where you are, and to all of you who've joined us today. So I'm going to give a brief introduction to our two speakers and then hand the floor over to them. So Pauline Frizelle is a professor at University College Cork, and we want to extend our warm congratulations on her recently being awarded her chair. She's a former speech and language therapy manager with over 15 years of experience working with children with a wide range of speech, language and communication needs. In 2008, she was the first speech and language therapist in Ireland to be awarded the Health Research Board Fellowship for the therapeutic professions. And in 2015, she was awarded an assisted Marie Curie Fellowship to begin the development of an electronic assessment of complex syntax at the University of Oxford. She has since built on this work through a Health Research Board Lead Investigator Award, comparing assessment methodologies and developing a robust and engaging assessment of complex syntax. Pauline is particularly interested in collaborative research projects with clinicians in the community and in the development of robust, theoretically driven interventions. She's led the development of the Language Through Music programme for children with Down syndrome and continues to work towards optimal use of keyword signing in schools. Pauline has recently received a 1.3 million Definitive Intervention Feasibility Award to complete a full definitive randomised control trial on the Happy Talk programme for children from areas of social disadvantage, and a 2.5 million award to lead a programme of research to develop consensus on reporting guidelines to be used in language intervention studies for children with or at risk of DLD. Cristina McKean is Professor of Child Language Development and Disorders and a Senior Academic Research Leader at the Department of Education at the University of Oxford. Before joining the department and after a career as a speech and language therapist, Cristina held academic positions at Newcastle University and the Murdoch Children's Research Institute in Melbourne, Australia, where she continues to hold honorary positions. She was previously Editor-in-Chief for the International Journal of Language and Communication Disorders. She leads interdisciplinary research with global reach, which develops and evaluates public health and educational practices and interventions to promote robust language development for all children. Her work is conducted through multidisciplinary collaboration and partnerships with young people, parents, professionals, and policymakers. Key to her work are considerations of individual differences, children and families' social and cultural context, and equitable systems, services and policy. So over to Pauline and Christine. We're really looking forward to a really interesting hour and a half.
Okay, so thank you very much for the invitation to speak today. Pauline and I are going to take it in turns in this session, and I'm going to kick us off with an introduction describing what we mean by active ingredients and why they're important to us as speech and language therapists. Then Pauline is going to summarise the findings from 2 systematic review papers which we published in 2022, which looked at the active ingredients in DLD interventions. We're then going to present some insights from 3 more recent studies. One about the intervention called BEST, where we're looking at how if you specify the active ingredients for intervention research, that this can support efficient intervention. And Pauline's going to present a paper about an intervention for people with Down syndrome. How much is enough, and can you have too much, are the questions she's going to be looking at there. And then we'll present a paper about DLD, comparing varying different schedules of delivery for DLD language interventions. We'll finish with some detail about where we're going next with our dosage and active ingredients research, and Pauline will describe the new TICKLED study, which she's leading regarding the development of consensus on how we report interventions in research. Okay, next slide, please. Okay, so as we know, speech and language therapy interventions are inherently very complex and can vary across multiple different characteristics. So we found in our collaborations in this space, which we've been looking at together, Pauline and I, over the last 5 years or more, that frameworks which were designed to describe dosage in speech and language therapy research provide us with the best opportunity to adequately capture the complexity and to characterize all of the moving parts that are going on within a speech and language therapy intervention. So all of the active ingredients, as it were. So let's just use the idea of a prescription of a medicine as an analogy for what might be happening in an intervention. So when a doctor prescribes a pharmaceutical intervention, they can vary a number of different components. So they can vary how much of the drug is in each tablet, how many tablets we take in a day, at what intervals over the day we take them, and for how long. And they can also vary what's actually in the tablet itself that we're going to take. What's the chemical components, as it were. So how all of these components vary between treatments can influence the effectiveness and the efficiency of the treatment. So this analogy is clearly a very medical model of intervention, and I know this can sometimes feel an uncomfortable fit with the wide range of things that we do in speech and language therapy. However, in our research, reviewing the evidence base for interventions with children with language disorders and developing new interventions, we found that thinking about the components of dosage in SLT interventions is a really helpful way to consider how evidence can inform our service delivery and provision, and also how we can design and deliver interventions for maximum effect. Okay. Next slide, please. So the model that we've applied and we've developed further in our recent systematic reviews was based on the work of Warren and colleagues and Proctor and Williams and colleagues. And it has 4 quantitative components and 1 qualitative component. So looking first at the 4 quantitative components of active ingredients, we've got dose, which, if we're using our analogy that we looked at earlier, is like the amount of drug in each tablet. Dose frequency, which is like the number of times in the day when you take your tablet. Total intervention duration, which is like the number of days you need to take to have the full course of your medicine that you've been prescribed. And cumulative intervention intensity, which is the total of number of tablets that you're going to take to complete the course. And then we have this 1 qualitative component, which is called dose form in these models. And this is analogous, if you like, to the content of the drug. What are the chemical ingredients which are included? Okay, next slide, please. So now to start to apply that model to speech and language therapy then. So in speech and language therapy, thinking about these quantitative active ingredients, first of all, when we're talking about dose, we mean the number of properly administered teaching episodes during a single intervention session. So in a vocabulary intervention, for example, that might be the number of times that child is exposed to a particular word during a shared book reading activity, for example. Or for a morphosyntax intervention, it might be the number of times that they repeat or produce a particular structure, for example. Or in an early language intervention, it might be the number of the times the child's communicative attempts are recast by the adult. So dose also has 3 subcomponents. This includes the average rate of teaching episodes per unit of time. For example, is the child getting 1 recast every 30 seconds or 1 recast every minute within their intervention sessions? The length of the intervention session is the next subcomponent. So is it a 30-minute session or a 45-minute session? And then the third subcomponent is the distribution or density of the episodes of intervention over the session. So for example, are your 15 recasts given in 15 minutes, or are your 15 recasts given over 30 minutes, for example? So the next component, quantitative active ingredient, is dose frequency. This is the number of intervention sessions per unit of time. So are you seeing somebody twice a week, once a month, for example, 6 times a year? What's the number of interventions per unit of time? The total intervention duration is the total period of time for which the intervention is provided. Is it a 6-week block? Is it a 12-week block? The infamous 6-week block? Is it something else? And cumulative intervention intensity is the product of all of those 3 components. So it's the dose multiplied by the dose frequency multiplied by the total intervention duration. So therefore, a client, let's say, who's receiving 30 recasts in 30-minute sessions given once a week for 6 weeks, their total cumulative intervention intensity is 180 recasts over that block of therapy. So these are all the quantitative components or active ingredients in interventions. Next slide, please. So now looking at the qualitative active ingredients. So this is what do we actually do, not how many times or how much do we do it in a session or in our interventions. So the qualitative active ingredients, as I said before, are often called dose form, which is analogous to the chemicals in the tablet and is obviously the most complicated part of what we do of our decision making as SLTs. What is it we're actually doing in the sessions? In the most recent framework, dose form is defined as commonly used techniques, procedures, methods of instruction, and intervention contexts that constitute teaching episodes. So let's think about those 4 elements in turn. So techniques are the specific actions or teaching behaviours thought to have benefit. So what is it that we're doing that we hypothesize is making a change for that individual? For example, these might include modelling or using sign or eliciting imitations for a child. So those are our techniques. Procedures refer to how those techniques are combined and in what order. So perhaps a therapist might provide 20 models before trying to elicit an imitation for a child, or maybe they might alternate between a model and an elicitation. So those orders and how they're combined are procedures. Method of instruction relates to the manner in which techniques are delivered. So in particular, the focus from previous models was very focused on the idea of whether intervention is implicit or explicit instruction. And this feels like it's a very important distinction. So whether we are playing with a child and providing lots of models, but the child isn't aware of what we're trying to do, or whether our intervention is explicitly saying to the child, right, today we're going to really think about those endings on those verbs today. Let's play a game and see if you can remember to use the sounds at the end of the word, for example. So it's that distinction. And the fourth component, intervention contexts, can also be further broken down into 3 subcomponents. So the first subcomponent there is the activity in which the teaching behaviour is being delivered. So, for example, is it within shared book reading or symbolic play or a board game? So you could use recasts and modelling in any of those activities, but that's the kind of carry activity that you're using to hold, to place the techniques within. The second subcomponent here is where the activity sits in the child-centred, clinician-directed continuum. So what degree are we following a child's lead, and to what degree is the therapist in control of the steps within the intervention? And the last subcomponent is about the degree of variability or uniformity in the linguistic input or materials used. So, for example, if you're teaching animal vocabulary, do you use the same picture of the dog over and over again, or are you varying the pictures of the dog that you're showing when you're providing those models, for example? So those are the current ways that we're trying to capture qualitative active ingredients. Next slide, please. Thank you. So now to think about why we should care about dosage and active ingredients. Why are they important to us? So I think we've probably all asked ourselves these sorts of questions about our practice. So we've asked ourselves, I did it a lot, is what I'm providing enough to make meaningful change? So putting that in another way, what's the minimum effective dosage that I should be providing? How much and what should I be giving to people? I think I often ask myself a question, is there a point where what I'm doing is not going to make a difference anymore? So is there a point where there's diminishing returns, where the individual's not going to make progress, or are they going to plateau in their progress and not receive the benefits from the intervention anymore? And then another one that I think we all wrestle with is, how can I make the best use of the available time that I can offer? So if we've got 6 hours or 12 hours that we can offer a client, are there ways of distributing what I do within and across sessions to maximise efficiency and efficacy? So is it best for me to do a big blast of something concentrated and then lots of follow-ups, or is it better for me to spread out my efforts for this individual client? And then finally, I think a question that we have to keep challenging ourselves with is whether or not our decisions about dosage and what we're delivering are based on custom and practice and on available resource, or whether they're actually based on evidence. And I suspect we'd have to admit that these decisions may be driven by the former and not the latter. And in part, this is due to lack of evidence, but not always. And I think what we want to do is show you that there is some evidence available about what we should be delivering and how we should be delivering it. We always need more evidence, but there is still evidence out there that we can use to underpin our practice. Okay, next slide, please. Okay, so yes, so it's therefore vital that we understand and document what works in SLT interventions in terms of active ingredients and dosage. And understanding dosage is clearly vital if we're to make maximum use of available resources. In stretched systems, we need what we're doing to be as efficient as possible if we're going to reach all of those people with needs. If there are ways to get results faster, we should be aiming to apply them. And if we're providing unnecessary or ineffective interventions, we should stop doing so. So I think we need to understand our dosages and active ingredients very carefully to address those issues. So providing the most efficient possible dosage isn't just about the financial bottom line, that's that dollar sign there. It clearly matters for people with communication and eating and drinking needs, and for their families as well. So the more efficient that we can be, the lower the burden for those families of attending sessions or working with speech and language therapists. Now looking at the little pink graph, also, if we can make benefits happen faster for our clients, then this must be positive for their outcomes too. The faster we can help resolve or ameliorate those difficulties, then the less time that individual is living with those difficulties or living with that severity of difficulty. So being more efficient is better, not just is better for money, material reasons, but is also better because of the experiences of the people with whom we work. A number of policy imperatives can push us as a profession to see as many people as possible and to think of efficiency in terms of numbers of people seen. And I think we need to push back on that. However, if we're looking at the brief, the nature of the contacts we're having, if we're having incredibly brief contacts with individuals where this waters down the support that they receive to the point that it's ineffective, then these approaches are highly wasteful. And I would argue, and I think I've said it before at other conferences, that not only is it highly wasteful, but I believe it's unethical. It's unethical for speech and language therapists to use scarce resources to deliver ineffective intervention dosages. And it's unethical to engage the emotional, financial and practical resources of people with communication and eating and drinking difficulties in interventions where there's no realistic hope of making a difference. We mustn't be removing children from their educational context, for example, to come and do an intervention that isn't going to work. They'd be better off staying in their classrooms. So we need to be really, really sure that what we're doing is going to make a difference. And finally, if we understand the dosage and the active ingredients of our interventions much more precisely, this will enable us as professionals to advocate with commissioners and service providers about what needs to be given to make a difference to children and young people's outcomes, or people with communication disabilities more broadly, and also for people themselves to advocate for their the type of support that they need to make a difference for them. Okay, next slide, please. So how can we make our interventions as efficient as possible? So manipulations in the qualitative active ingredients of an intervention influence the amount and nature of learning which takes place during an intervention. And Pauline is going to talk some more about some specific findings that we pulled together in our systematics reviews that showed that if you make the techniques and the processes as specific as possible, you can get results faster, more quickly for individuals and more effectively. Yes, as I say, so manipulations in these active ingredients can affect the amount of learning that takes place. If we're aiming to increase vocabulary, I mean, this is sort of obvious in a way as a speech and language therapist. If we're aiming to increase somebody's vocabulary, we're not going to start working on how to suck through a straw, for example. So it's obvious that what we do in a session makes a difference. So that's obviously a really silly and gross example, but as you'll see in the section which Pauline will present, there are finer grained and more subtle manipulations that can really make a difference as well. Importantly, we believe really strongly that deciding precisely how to make such modifications or manipulations must be driven by our knowledge and theories about the learning mechanisms that exist that are relevant to the targeted domain, and our theories of the nature of the underlying impairment of the client group that we're working with. So if, for example, we believe children learn about marking plurals through exposure to numerous contrasts, then we might create a card game where children hear and generate multiple exemplars of both singular and plural nouns. So we have our duck and our ducks there. And that's driven by our theory that we believe contrast helps children to learn, for example. And then if we believe that children with DLD have phonological processing impairments, which affect their ability to identify these contrasts, we might aim to make those plural markers more salient through perhaps using colour or shape coding, like in our third set of ducks there. Or we may aim to simplify the stimuli choosing only plurals which don't evoke a cluster at the end. So maybe we'll start with shoe and shoes, first of all, to reduce the phonological processing for an individual, and then build up to more complex clusters, for example. So our techniques that we're using here and our choice of stimuli are driven by theory. Next slide, please. And so designing and delivering optimal intervention dosage regimen, therefore requires us to engage with theories underpinning the interventions we use. We need to understand them so that we can consider how best they can be applied for our individual client in front of us and with the constraints of our service delivery models. So we're saying that to provide optimal interventions, we need to engage with the theory underpinning our interventions. Okay, next slide, please. So now I'm going to hand over to Pauline, who'll start to unpack some of that finer detail which has been examined in research to date. Thanks, Pauline. Over to you.
Thanks, Cristina. Okay, so what do we know about active ingredients in interventions for children with DLD? So we conducted a couple of systematic reviews, one which focused on the quantitative active ingredients of therapy, the dosage, and the other on the within-session qualitative active ingredients. So I'm going to summarize some of the main findings from our reviews, but before I do that, I'm going to pull out a few interesting papers to highlight just a couple of concepts for each domain. Our systematic reviews were focused on phonology, morphosyntax, and word learning within DLD. However, because we weren't including those with speech sound disorder, there was very little reported on phonology, specifically for children with DLD. So I'll focus on vocabulary and morphosyntax. And although some of the concepts I'm talking about will go across domains, many of them don't. And so I'll report on the domains separately before I summarize. And just also to say that my summaries will then be based on many more papers that go beyond the ones that I've highlighted here. So you might think in the summary, where did that point come from in the papers that she's just presented? But I'm only just going to talk about a few key papers. Otherwise, it would be very boring for you all. So as Cristina said, it's no longer enough for interventions to be effective. We need them also to be efficient. And we want to think, will one intervention technique achieve the same result as another, but with half the number of sessions or half the amount of input? What is it that works most efficiently? So what do the systematic reviews tell us? So I suppose one of the concepts that we need to think about when thinking about dosage and the frequency with which we see someone for therapy is this idea of spaced versus more concentrated learning. So there's a theory that learning is more efficient when we space out the number of teaching episodes over many sessions, rather than having them very concentrated into one or a few sessions. So the idea being that if treatment sessions are spaced out across different days or weeks, then this allows for new information to be re-encoded during each session and then consolidated between the sessions. On the other hand, then, your concentrated treatment doesn't offer children that same opportunity for consolidating knowledge after they've just encoded it. And so we know that children with DLD have been shown to have encoding difficulties and that they require a greater number of exposures to both vocabulary and syntactic forms than children with typical development. But unfortunately, within the literature, there's considerable variation in what is considered spaced or concentrated in treatment delivery. So one person's concentrated might be 30 minutes 4 times a week for 6 weeks, or it could be 30 minutes a day for 8 days. So it's very difficult for us to really get to the bottom of what's been driven by the spaced versus concentrated, because it's very often not comparing like with like. But I'm going to highlight a few studies. So first, a few papers from the literature in relation to quantitative implications for treatment. So if we look at some of the work that's been done exploring this issue within a session, first of all, Proctor, Williams and Fay did a study where they compared 30 recasts, which were spaced across 5 sessions, versus 30 recasts concentrated in 2 sessions. And they found no difference in the spaced versus concentrated approach. So it was ineffective at both densities. So we can acknowledge here that the dose is very low. Another study carried out by Plant and colleagues, they compared 24 recasts given in a 30-minute session versus 24 given in a more concentrated 15-minute session. So here we found positive outcomes, but there were no differences in how children performed between the conditions. So this is extremely valid and important finding in the sense that the high-density dose delivery method would seem to be more efficient. And it allowed for shorter sessions, or it could allow for more targets within a session, for example. So there was no spaced advantage. And so both of these studies would suggest that the overall dose is what matters rather than how the doses are distributed. So if we look then, so that, I suppose both of those studies we were looking at within the session, what we can do within the session. But if we look at dose frequency across the sessions, there are a number of studies here that have used a range of very typical techniques that we use, like modeling and recasting and imitation, expansions. The first two studies here manipulated different dose frequencies. So we can see here 4 times a week by 6 weeks, which came to 24 sessions, twice a week by 12 weeks, which also came to 24 sessions. In the second study, we see 3 10-minute sessions within a 4-hour period, 5 days in the week, which came to 30 minutes, or 1 30-minute session, 5 days a week, 30 minutes. So importantly, both of them found no difference between the spaced and the concentrated condition. So it didn't matter whether the frequency was very concentrated or the frequency was more spaced out. The third study here that I'm showing you is by Smithlock and colleagues. They did find a spaced advantage, but importantly here, the dose, so the number of properly administered teaching episodes, was not controlled for. So what we seem to find in the literature overall is that if the dose is controlled for, we don't see a spaced advantage. And I'll move over then, if we look at the word learning literature, Holly Storkel and colleagues have done some really nice work in this area. So where they manipulated children's number of word exposures in a book reading context. So the children either received 12, 24, 36 or 48 exposures. And so the dose per session depended then on the treatment intensity. So for example, if you had 12 exposures, then the target word would be repeated 3 times in each book and the book would be read 4 times. So the response to treatment improved as the intensity increased, which is what we would expect, from 12 to 24 to 36. But interestingly, once we went to 48, there were diminishing returns. So 36 exposures was deemed to be optimal. And building on that work, then they manipulated how those 36 word exposures were given. So if they tried a 4x9, which was 4 exposures to the target word, so a dose of 4, but 9 repeated readings. Or they compared that to a 6x6, which was 6, a dose of 6, so 6 exposures and 6 repeated readings of the book, or a 9x4, which were 9 exposures to the target word and 4 repeated readings of the book. And the number of weeks then of treatment varied from a low of 5 weeks to a high of 12 weeks. So the results showed that children with DLD learned a significant number of words during the treatment, regardless of the dose and dose frequency format. So again, the frequency was not what mattered so much as the overall dose, the overall number of exposures. Interestingly, in this study too, there was significant forgetting of newly learned words in all the formats once the treatment was withdrawn. So 1 week post-treatment, 40% of the words that were correctly defined at the end of the treatment were forgotten. So this is something to really bear in mind when we think about how long after treatment we measure success. So if we're always measuring it immediately post-treatment, what are the implications of that? And am I really looking to see at what a child has learned? So I'm going to try and summarize in general the information in terms of the quantitative implications from all the literature, going beyond just those few studies. So thinking about dose, first of all, in the session and beyond. There are certainly gaps in the evidence and we don't have all the answers from our reviews, but a clear finding emerging from the reviews is the need to ensure that the within session dose and the intervention intensity is high. So whether that's daily or weekly or over 6 or 12 sessions is less important than the overall amount. And I suppose the next point to make is if we're to maintain high levels of within session dose, then we need to be clear about what constitutes a dose. So for example, for a given intervention, therapists need to decide if a dose is only when the child is required to do or say something, or if the input from the therapist is also a dose. Or if you're going to divide them up into what might be an expressive dose, so the output, versus a receptive dose, the input. So we need to be really clear about that. What is our dose or our teaching episode? because if we can maintain a high dose, then we can reduce the frequency of the intervention, and we can also reduce the overall length of the intervention. So it's about what we do cumulatively that's most important. And in relation to what we do cumulatively, the literature suggests a minimum requirement for children to achieve their goals. And so we see this in the example of the 36 word exposures, which were optimal. But it does seem that the density of the doses doesn't matter as much as the number of doses. So there's tentative evidence that the same results can be achieved in a shorter time frame if the within session dose remains the same and reasonably high. So we have the example of the 24 recasts in 15 minutes versus 24 recasts in 30 minutes. So the number of doses is more important than the length of the session. And so this has a significant impact on treatment plans in that it could make time available within a treatment session to address other goals, or to allow for shorter sessions so that children are withdrawn from a classroom, for example, for much shorter time periods. Thinking then about therapy models. So what about spaced versus concentrated? So we don't see any advantage for spaced with or between sessions in terms of the number of times we do something, the number of recasts or the number of word exposures, if all other aspects of dosage are controlled for. And if we had found that there was an advantage for space, then that would be an argument for seeing someone fortnightly. But we know now that overall dose appears to have greater impact on children's learning than the frequency of the treatment schedule. Weekly or fortnightly sessions are acceptable dose frequency schedules, but only if the dose per session is high. And little and often is also potentially effective. So enabling flexibility in scheduling so that we can accommodate parents or educational practitioners. So we can actually make a range of models work, but only if we pay attention to the within session dose, the teaching episodes, and our goal for how many of those we would want to achieve within a session. On the other hand, more is not always better. So too high a dose can result in diminishing returns. So potentially caused by reduced attention, or when a target becomes overly familiar, and it's not going to be the same for everyone, but we can use the evidence to guide us in terms of number of word exposures, to use that as an example. But then if we see that the child is disengaged or if progress is plateaus, we obviously recommend changing the intervention target. Unfortunately, there's no magic number for dose or session frequency across language domains, but there is sufficient evidence to suggest that we have to move away from the practice of delivering a number of predetermined intervention hours or sessions and think more about what the cumulative dose is that we're aiming for. So continuing treatment until a child reaches a pre-specified criterion for success would align much more closely with the evidence. And as Cristina said, we really need to think about the ethicality of removing a child from the classroom or asking parents to bring children to therapy for an intervention that's not given at a sufficient dosage that we know will affect change. And so our service delivery models, obviously they need to be driven by evidence, and we all know that, but it's very hard within the constraints of custom and practice to change. So I think one of the big things that we can control is what we do within each session. So I'm going to move on now to the implications of some of the qualitative active ingredients. Again, I'm going to highlight a few papers just to illustrate some concepts, and then I'll give an overall summary of what we've pulled from the literature. So the first concept I want to talk about here in terms of qualitative active ingredients is how variable is your linguistic input. So we know now that highly variable linguistic input seems to facilitate grammatical morpheme learning in children with DLD. So in one study, using recasting as the technique, children were randomly assigned to a high or low variability condition. So low was where they heard 12 verbs twice, each during recasting, and high was where they heard 24 different verbs once during treatment. So the dose of 24 was equal across both conditions. And intuitively, we might think that hearing 12 verbs twice would be better, as we know that children, at least in word learning, require repeated exposures to aid their learning. But actually, it was the group that were in the high variability condition that only heard the verbs once that showed significant change. So the implication in treatment here is if you're targeting a morpheme, for example, third person singular or past tense, then you should do it with lots of variation in the verbs that you use, rather than lots of repetition of the same verbs. If you think about it, it's about learning rules in terms of morphosyntax. You're trying to get a child to understand and to apply the rule. And so it's quite hard to extract a rule if you only hear something repeatedly with the same verb. Kind of in keeping with that, the next kind of concept I want to talk about is a complexity-based approach. And this approach appears also to enhance treatment effects. But whether the effects are driven by variability or driven by complexity, we're not really sure. And so from a clinical perspective, I think variability is probably easier to operationalize. And the premise here behind a complexity-based approach is that children begin with harder verbs first, and then while they might be slower to show initial gains, they will speed up as they learn to generalize. So in this study, half the children began treatment with easier to inflect verbs, and half the children began with harder to inflect verbs. And the others were looking at children's ability to produce the regular past tense. And you might say, well, what's an easier to inflect verb and what's a harder to inflect verb? So the inflection difficulty was determined by the frequency with which that morpheme is used with that verb, the phonological complexity of the verb, and what they call the telicity of the verb. So that's how complete the event was described by the verb. So a telic verb would be one like drop, where the event, excuse me, where the event is complete and where the action is complete. And an atelic verb or an atelic verb would be something like play, where the event is more ongoing. So the hard verbs were those that were atelic, that they were rarely inflected with the past tense, and that they ended with phonologically with stops or fricatives or affricates. Whereas the easy verbs were ones that were commonly inflected with the past tense, and they ended in vowels or glides or liquids or nasals. But interestingly, overall, the hard group first made the greater gains. So I think as well that this isn't necessarily intuitive to us. So there are some potential similarities between a high variability approach to treatment and a hard first approach, in that children frequently exposed to many examples of easy verbs. That happens all the time in the ambient language, and that is in line with a low variability approach. They're hearing many of the same words again and again, and in hearing those verbs, they serve as an initial platform from which children might begin to observe a morphological rule. But it's only when children are exposed to less common examples that they can more clearly see the rule and learn to generalize it. So exposure to less common verbs automatically increases the variability of the input. So rather than trying to think about complexity, it might be easier clinically to focus on increasing variability, in the knowledge that by doing that, you're also probably increasing complexity. And the third concept in this section that I want to kind of highlight is around, we talked about linguistic variability, but also object variability. So increasing the variability in how an object is represented in treatment also has the potential to improve children's ability to generalize their lexical knowledge and to increase intervention efficacy. So in this study, the physical representation of the words was manipulated. So half the children were trained using 3 different objects for each new word targeted. So for example, if the target word was hinge, for example, the images were of 3 different hinges. The remaining children then were trained with 3 identical objects representing each target word, so where the images were all the same. So when children were tested on the items that were used within the treatment, there weren't any group differences, which is probably what we would expect. But when they were tested on generalization items, then the high variability group performed better. And this makes sense because as if you see lots of different versions of the same item, then it's much easier to do some kind of semantic feature analysis and figure out what is it that makes a hinge a hinge. So just to summarize some of that, thinking about variability and complexity, think about linguistic variability and object variability. If you're targeting, for example, a morpheme, then vary the verbs that you use rather than using lots of repetition of the same verbs. Avoid using too many common verbs. By using harder verbs, you're going to help children to extract the morphosyntactic rule more readily. And if targeting vocabulary, vary how the target referent is represented. Use as many different images as you can, because that will make the characteristics of a given object much more explicit for the child. So the next study I wanted to refer to in relation to qualitative active ingredients relates to the implications of working in a small group or in pairs. So in this study, children were seen individually where they worked on their own morphology target, or they were seen in a pair where they were exposed also to their partner's target, which was different from their own. And so while there were positive effects in both conditions, children who received treatment in the pair didn't get any incidental benefit of the exposure to their partner's target. And so I think that's a very significant finding. They were using here modeling and enhanced conversational recasting, which basically is where the clinician uses attentional cues to get more attention from the child. They position themselves more closely to the child. It's very much about getting the focus and the attention. So I suppose the message here is that unless the child is focused or attending to the particular morpheme that you're working on, then they don't seem to get any incidental benefit from being exposed to what another child is working on. So they would need to be much more actively participating and engaging in the activity. Next, in terms of techniques and procedures, so just to summarize, this literature gets very confusing between what was done before and what was done after and which technique and what was the order. But to try and summarize, there are, I suppose there are a number of studies, many studies really, that show the advantage for expressive practice. So we really need, where at all possible, to be giving children the opportunity to engage in some kind of expressive practice. Prompting a child to produce an utterance with modeling or recasting is more effective than recasting on its own. So that's one example. So even at lower doses. So even though the doses of the prompting were much lower on the recasting, when recasting was done on its own, recasting has a much higher dose than when prompting and modeling was coupled with recasting, so where the dose was lower. But the fact that the child got a chance to engage in some kind of expressive practice compensated, if you like, for the lower dose. Cued elicitation, another way of getting child productions, was also more effective than recasting. Although in this particular study, the recasting dose was a little bit high. Sorry, the cued elicitation dose was a little bit higher. With higher doses, the addition of modeling post-recasting seems to consolidate child learning. And interestingly here, so the modeling was done in a form of like auditory bombardment. So when the auditory bombardment happened after the recasting, it seemed to really consolidate child learning. But when the modeling or the auditory bombardment happened first, that wasn't the case. So we can see that some of that work shows us how the procedure does matter. The order in which we do things does matter. However, I would say that children with higher levels of language seem to be less sensitive to the order of techniques as those who are younger and have lower language levels. So the order of techniques seems to matter more for children who are younger. So the next area I'm just going to quickly talk about is method of instruction. And I suppose the first thing to say here is be aware of the method of instruction you're using. So many techniques have elements of both. And while we do talk about some approaches being primarily explicit, for example, the shape coding is a very good example of that, where the rule is explained and it's very much aiming for an explicit approach. But there are lots of implicit techniques embedded in that. So using things like imitation. So I think just be aware, first of all, and think, what is my method of instruction here? Am I engaging in an explicit, or what are my techniques that are also implicit here? Interestingly here, even with a lower dose, an explicit approach has been found to be more effective than an implicit one. And I think that's very powerful. So that's where, we talk about the qualitative active ingredients, the quantitative active ingredients, but obviously there's an interaction between the two. So by using an explicit approach, we can get away with a lower dose. Adding an element of explicit instruction to an already implicit approach appears also to enhance learning. So I suppose the main point here is that if children are at an age or a language level that they can follow a simple explanation or a rule, then always give it. Clearly, you need to have some level of metacognitive, metalinguistic knowledge to be able to do that. So with very young children, we can use other methods like signing to try and make things more explicit. So moving then just over to the word learning literature, there's one study here I kind of wanted to highlight. And this came out of Larry Leonard's lab, and it's to do with asking children. So what they did was they found, first of all, that children who were asked to retrieve words with other words intervening, that it helped with their word learning and helped with their retention more than if they just completed the task without intervening words. So basically in the treatment session, they had sort of three elements. They had what they called a study, a retrieval, and a study. So the study was where children were exposed to the word with its associated picture and a simple word definition. Then a picture prompt was given where the child was asked to recall the word and the definition, and then they were initially exposed to it again with the definition as feedback. So when children were asked to retrieve, it was either immediately after the first step or with two words intervening. And children performed better when there were words intervening, despite the fact that this condition had a reduced expressive dose. Now, I should say that overall, the learning wasn't great and they didn't learn a huge number of words. But if I'm highlighting this because we talked about spaced and concentrated earlier in terms of the number and how we space out the number of things that we do. Was it the number of sessions over weeks or the number of doses within a session? But here, this is a form of spacing, and it's not really to do with the number of exposures. It's rather to do with intervening material. So visiting something and revisiting it after something else has been introduced. So just to summarize that, so thinking about word learning, new word learning, it's better to create space between the initial exposure of something and the information given, and asking child to retrieve that word information. Thinking about semantic-based therapy, the type of word definition that you provide should be driven by the desired outcome and also by the child's level of language. So I'm taking this kind of based on some work that was done where words were taught with a different type of explanation. One with a short dictionary explanation, not one, but one set of words were taught with a short dictionary explanation, one with an explanation with given kind of the specific reference to the context of the story, and one set of words where they used a combination of both. And basically the short dictionary explanation was better for word use, but the explanation given within the context of the story was better if you were thinking about word definition as the outcome, which makes sense. And then the combination of both approaches worked better for those who had higher levels of language. So hence, we need to think about what's our desired outcome from the work that we're doing. Just to highlight two other points here, video and static stories have been found to be equally effective in children's word learning. However, when music and sounds were used for effect, they actually interfered with children's learning. And that was moderated by children's language ability. So children with more severe DLD learned less in the presence of music or sounds. And I wanted to highlight that because I think we're moving very much more towards the use of apps and many more interactive videos. And so I thought that's an important thing to highlight. And lastly then, very intuitive but it's nice to have the literature there to support it, that we know that iconic gestures, so those that would have some kind of semantic content. So if I flap my hands to show the wings for a bird, that kind of gesture works better to support word learning than the kind of attention getting, so which is very intuitive and what we would expect. So that brings me to the end of this part of what I'm going to talk about. But we're going to talk about new insights from 3 recent studies that we did next. But before we do that, I think we're going to take maybe a 3-minute break.
Last time. So I'll pick up, as Pauline said, and start talking to you about some newer insights around active ingredients, exploring the active ingredients of interventions. And I'm going to start us off by talking about BEST, Building Early Sentences Therapy. So So as Pauline demonstrated, quite subtle manipulations in the qualitative aspects of active ingredients, the dose form, can bring about differences in the efficacy of interventions. And for this first sort of new insight spotlight, we wanted to talk about an intervention which we designed with a very specific theoretical focus and a set of hypotheses about what would make an early intervention work. So what we thought would be the most important active ingredients to embed into this intervention. And we designed the intervention to deliver lots and lots of these active ingredients in a very short space of time. So as I say, this intervention is called Building Early Sentences Therapy, or BEST, and was designed a number of years ago by Sean Pert, Carol Stowe and myself. It's a specialist language intervention for children aged between 3.5 and 6 years who need support to use 2, 3 and 4 clause element sentences. The active ingredients are based on usage-based or constructivist models of language acquisition and our knowledge of the learning mechanisms and the learning impairment, language learning difficulties of children with DLD. It's delivered in 16 sessions, for 15 minutes for each session, twice a week in small groups. So it's a very short, sharp, quick intervention. And it has the potential to be a highly efficient model of intervention if it works, because it's, as we say, it's 15 minutes twice a week within a group session. So it's a very efficient mode of delivery. So BEST, as I say, is based on usage-based or constructivist linguistic theories of language development. And these theories suggest that children's language moves over development from very fixed, rote-learnt constructions towards more flexible and abstract representations over time. And as you get more abstract representation, this makes your language learning more efficient, and then this can accelerate language learning. And so these abstract constructions are representations, are of argument structures and syntactic categories. And when they form, they make the children much more efficient in their learning. These theories suggest that the drivers of this change are the nature of the input that the child hears, and that's in terms of the amount that they hear, the content of what they hear, and also how those structures are distributed throughout the input. And then the other drivers of change in children's language knowledge are the cognitive tools which children bring to bear on the process of language learning. And we hypothesize in BEST that by systematically manipulating the nature and quantity of the language a child hears, that BEST can promote the development of abstract representations and so accelerate this language learning. And we're manipulating the input to try to support children to leverage the cognitive tools that typically developing children use to support their language learning. So how do we manipulate the input in BEST? Well, over 16 sessions, the intervention exposes children to 11 sets of paired verbs. Each pair has the same predicate argument structure. As a reminder, back to your university days, predicate argument structures are the structures of simple sentences which are possible with a given verb. So what are the structures that are possible? For example, is it agent and action, patient, agent, action, patient, locative? What semantic roles can you put around a word to build a sentence? So within a joint action routine, what happens is that with toys, children first see an adult act out a set of actions whilst providing a verbal model of the appropriate sentence and accompanied by signs. And then they're encouraged to produce sentences with the same predicate argument structure, but a different verb. So in phase 1, which we call input with variation, the child hears sentences combining a verb, for example here, wash, used 3 to 6 times, with most of the sentence held constant, but with one slot in the sentence frame varied. So here we've got the Teddy's washing a cup, the Teddy's washing an orange, the Teddy's washing a banana, and so on. So the children see the adult act out the activity, hear the adult using the sentences, and seeing sign alongside those sentences. In phase 2, which we call output with variation and contrast, the child again watches the adult act out the event which is an event with the same predicate argument structure as phase 1. So here that would be agent, action, patient. But here we have a contrasting verb, and the child is encouraged to describe what they see. So that we just ask them, what's happening now as we act out the activities. The adult recasts any attempts that the child makes verbally and also with the signs. The child's then allowed to act out the events with the toys themselves, while the adult again provides a model of the target utterances. There's a high number of repetitions of these target sentences. And this is repeated a number of times, again, with here, as we see, with a frame held constant and one slot varied. So here we've got the man is eating the banana, the man is eating the apple, and so on. Within each session, children are taken through this two-phase process 3 times and with 3 different verbs. 3 different verb pairings, sorry. So each session therefore exposes the children to 6 different verbs. And they try to use 3 different verbs in each session. A homework booklet with all of the verbs targeted in each session is also sent home for home practice. So importantly, the intervention, as I've said, uses sign to represent not just content words, but also morphology. So signs are used throughout to represent, as I say, content and morphology. And the morphology comes from Paget-Gorman sign system. Those are the morphological signs that we use. And our website has videos of all of them. We rotate through the verb pairs over the course of the 16 sessions, and children don't have to master any of the structures to move on. This is all about input. So we're manipulating the input the child hears, and we're manipulating the things that they attempt to say, but we don't need them to master an earlier construction before we move on to a later construction. They're just moving through them over the whole 16 sessions, and we find that they achieve mastery over the 16 sessions if we do it that way. By the end of the intervention, they are able to use all of the structures. So what are the cognitive tools that we're trying to leverage in BEST? So in BEST, we're trying to manipulate the input to exaggerate the aspects of language input which typically developing children use to move from the fixed rote learned constructions to more abstract representations. And through this highly exaggerated input manipulation, we hypothesize that we're compensating for the processing problems found in children with and at risk of language disorders to support their application of these cognitive tools of language learning, which otherwise are difficult for them to leverage. So these are all the cognitive tools that we believe that we're supporting children to apply in their learning during a BEST session. I won't talk you through all of them, but I'll give you a few examples to show how we think what we're doing is helping children to use these tools. So, for example, thinking about variation around the verb then, so that variation that we were talking around where you've got the slots and the frames, promotes children to use schematization. So by this, we mean finding some simple rules about the sentence elements that can be combined. So children are creating schemas like the X is washing the Y. So they understand that they can have that sentence frame and they can put different items in the X and the Y slots, as it were. So they understand that different nouns can be slotted in and around the verb. And that's helping them to begin that process towards having an abstract representation of how a sentence can be constructed. We also hypothesize that this variation around the world, around the verb, is helping the children to use categorization as a strategy, a cognitive tool. So it supports children to create categories of things that can be eaten, categories of things that can be washed, for example, or categories of things that can do eating or things that can do washing. And this supports children's learning of the semantic roles that can occur in a sentence. So this is based on experimental research. You can see the references at the bottom with typically developing children which have tested how these different manipulations and input can affect learning. And we've drawn all of our techniques from this body of work in usage-based linguistics. Okay. Another example then is that we hypothesized that by contrasting two sentences with different verbs but the same predicate argument structure is promoting children to use the cognitive tool of analogy. So here they're creating representations that are even more abstract than that schema that we talked about previously, and they're seeing commonalities across sentences in the way that the different elements within the sentence relate to one another. So the children see the commonalities across the sentences at an abstract level to create structures like agent, action, patient. So when they saw Teddy's washing the banana and the man is eating the banana, they were able to abstract this idea that, oh, we can have structures that are agent, action, patient across different verbs and across different sentences. So that contrast, we think, is helping promote analogy. We also think that by having non-overlapping sets of nouns as agents or patients is also promoting analogy. Again, as we say, this is based on experimental research with typically developing children. So in BEST, agents are never patients and patients are never agents. So you never have a banana eating a teddy, you always have a teddy eating a banana. That's a silly example, but yeah, I hope you get the idea. And that's shown to support this idea of creating this and using analogy to create these more abstract representations. And then these are some last strategies that we'll talk about now. We also believe that by keeping the morphological frame constant, so throughout BEST, it's always X is Y-ing the Z. So we're keeping the grammatical morphemes around the sentence consistent across the input. And by signing both the content and the morphology, we believe that this is supporting children to use bootstrapping and distribution analysis to notice the patterns and commonalities across the structure. So distribution analysis is spotting patterns in terms of the morphology and seeing that a the comes before an agent or a noun, for example. The ing is always attached to a verb. And so by spotting these patterns in the morphemes, this is again supporting children to then use that analogy to develop their structures of predicate argument structure. So using the sign and using this constant morphological frame, we believe, is drawing children's attention to these patterns and regularities in the input. So does it work? So I would say, yes, it does. And I think what the reason that we're presenting it here today is that we think it demonstrates how a highly intentional manipulation, theoretically motivated manipulation of active ingredients really does pay off. So we know that BEST is effective in improving production standard scores when compared to treatment as usual. So this is one of my PhD students, Anastasia Trabash's work, where she compared BEST to treatment as usual in early years settings. And she also compared BEST with and without the use of sign. And she demonstrated that the signing of the content and the morphology is an active ingredient of the BEST intervention. And we're really thrilled that BEST produced change in standard scores, not just raw scores, in a standardized test. And we also know, and this is a paper that's under review currently, we know that it pays off in a cluster randomized controlled trial that we completed recently and which was funded by the Heather van der Lely Foundation. We know with 102 children, we know that BEST is more effective than an active control. So it's not just more effective than treatment as usual, it's more effective when compared to another intervention delivered with the same dosage and the same intervention intensity. So it's better than an adapted DLS that we used in this study. And we got a large effect sizes for production standard scores, so Cohen's D of 0.55. And using the EEF guidance, this is equivalent to a gain of 7 months when compared to ADLS. So I think the point that we're trying to make, and I hope I'm not labouring it too much, is that we believe that by really detailed specification of the theoretically motivated active ingredients, this allows us to be very intentional in our design and to provide high intervention intensity and provide a highly efficient SLT intervention. So 16, 15-minute sessions in small groups produces that output if we keep the dosage really high and really intentional about what we're trying to do within a speech and language therapy session. Okay, so that's enough from me. That's my example, and I'll hand over to Pauline, who has two other papers to talk through.
Anyway, thank you. I'm going to follow on with another study, which was a feasibility study, and this was looking at an online language through music program. But specifically in the context of what we're talking about here today, we looked at the impact of dosage on the vocabulary outcomes of young children with Down syndrome. Okay, so because it was a feasibility study, there were 3 phases to this work, and we wanted to find out, first of all, what do parents consider important when implementing a home-based language through music intervention with young children with Down syndrome? And then after on the basis of our findings, we developed the program, and then we wanted to look specifically at the effect of dosage on the vocabulary outcomes. So our vocabulary outcomes were understanding and use of signs, words said in imitation, and spontaneous use of words. And the last phase of this study then was asking parents, how acceptable is the intervention to you? So it was a mixed method study design with 3 phases. So first of all, we examined the feasibility of the approach in practice, what parents considered to be important in terms of even how many, whether it would be in the morning or whether the intervention would be the afternoon, or the timing of it, how often it would be, what it would entail, and so on. We then collected outcome data, which would hopefully add to our knowledge of real-world effective online interventions, particularly with respect to dosage. And then thirdly, we took some process data, so where we tried to identify factors that would improve the probability of successful implementation into the future. So what I'm focusing on here today is this section 2, phase 2. So phase 1 involved a questionnaire and a survey, and based on the findings from that, in particular the fact that different times of the day suited different people, as well as the fact that people found it particularly useful to play recorded sessions back. So we decided to go with a video-based intervention, which could be, integrated into children's day at whatever time was convenient for the family, and it could also include all the family members, siblings, etc., and it could be played multiple times and then used as a reference for learning the signs. So we developed a 12-week video-based intervention, and we chose songs that were going to represent familiar, easy-to-remember melodies, but the vocabulary then was altered to reflect the Down syndrome education checklists, which are very much based on the CDI, but with some additional outcomes. The vocabulary was very much centered around daily routines, around common activities, meal times, bath time, people, etc. So, as an example, Baby Shark made its way in there, but instead of singing Baby Shark, do 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 do, we sang Take a Bath, do 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 do, or something like that. So we had 8 unique videos, and the final 4 videos were a composite of the songs from the previous 8 videos. And within each video, the vocabulary exposure was obviously very controlled because we were using songs. So we knew exactly how many times somebody was being exposed to each vocabulary item. Each video involved the demonstration of the signs first, followed by 2 songs, each of them sung 3 times. So first of all, they were sung with sign, then they were sung with sign plus objects and background images, and then they were sung where we omitted certain signs and words to encourage the children and families to participate and make it more interactive. The video lengths ranged from about 11.5 to just under 21 minutes, and the song lengths ranged from 1.5 minutes to just under 3 minutes. So there was quite a bit of variation there. So our child participants they were very young, so they ranged from 9 to 45 months of age, with similar proportions of males and females. We didn't intend to include children below 12 months, but some parents came forward, and when they heard about the intervention, they wanted their children to be part of it, and so we weren't going to turn them away. Following recruitment, the children were randomly allocated to one of 2 dosage groups. So we had data for 68 participants. The high dosage group had 33, and that was 5 times a week. The low dosage group then was 35, and that was twice a week. And we also asked parents then to log the number of times that they watched the video each week. We were conscious that it was an online intervention, and so parents weren't going to meet other parents. So we had a Zoom meeting each Wednesday with 3 time slots to provide support, to ask questions, share ideas. And the videos were emailed on a Friday of each week, and that's how they access them through email. In terms of our outcome measures, we used the parent report measures, which were the Down syndrome education checklist, which, as I said already, are based on the CDIs, but they include understands and signs, using words in imitation, and using words spontaneously. So we had 50 valid measurements for all 3 outcomes. Participants in both high and low dose groups all showed improvements in each of the 3 outcomes over the 12-week intervention. But unfortunately, despite our randomization, we had significant between group differences at baseline. So our low dose group performed significantly better on the vocabulary checklist than the high dose group. Now, our statistician said that the chances of that happening are like winning the lottery, but it happened. So that was unfortunate, because it meant that one group, and really our randomization should have dealt with that, but it didn't. So our low dose group were performing better on the baseline at the outset. So we adjusted for those differences at baseline, and after we adjusted, then there were no differences between those in the low dose group and those in the high dose group. So that appeared then that there was no additional benefit to getting a higher dose. And that's not what we expect to see. But of course, the story is a little bit more nuanced than that. So we conducted a set of exploratory models to see whether the impact of the intervention differed based on children's performance at baseline, and it did. So those who were better and scored higher at baseline were able to benefit more from the higher intervention intensity. So this suggested a critical minimum performance was needed in order to get the maximum benefit from the high dose. So as a guide, children who had a minimum of 6% of the vocabulary on the Down syndrome education checklist, they were able to benefit from the higher dose more. So that was about 28 vocabulary items that they could either understand or sign. Finally, although our participants were randomly assigned to 2 different dose frequency groups, we knew that there were going to be practical issues for parents adhering strictly to those dosages. And so we anticipated that there would be considerable dose frequency variability within the groups. So we knew that some people who might be randomly assigned to the 5 times a week group might have felt, oh, I haven't a hope of doing that. I can only do it twice a week. And equally, we felt there were some people in the twice a week group who said, oh, I'd like to be doing it more. But because it was a random allocation, we couldn't choose people according to their desires. So they were randomly allocated. But what we did say to them is, look, we don't mind what you try and adhere as closely as you can to what we've asked you to do, but we don't mind if you don't do that, but just please do let us know. So because we had this within group dose frequency variability, we were able to use an exploratory dose response model, like a statistical model, to explore the potential effects. And we found that higher dose across all children was actually associated with better end of study outcomes. So 1 unit increase in participants' weekly average dose was associated with improved outcomes. So just to kind of summarize, there was improvement in all who took part. Our initial analysis suggested that there was no additional benefit to receiving a higher dose. But when we looked further, we saw that there was actually an interaction between how effective the intervention was and how children performed at baseline. So those who performed better at baseline benefited more from the high dose. Because we used parent logs, then we could see that the higher doses across all children were actually associated with better end of study outcomes. So really the effective dose frequency differs according to specific child variables, and our findings suggest that pre-intervention language levels is one such variable. And I suppose that's really very much in keeping with Vygotsky's theory of zone of proximal development, in that children who haven't yet learned to use words or to sign, or who were signing minimally, required much more scaffolding than was provided in our videos. In contrast, those who had a more substantial repertoire of words or signs pre-intervention, they appear to be capable of learning in a more independent manner, and consequently the format of the intervention was sufficient to support them, and they could get the benefit of the higher dose. Just as a minor point, well, it's not a minor point, but in the context of what I'm talking about here, the program was acceptable to parents, but many parents did report that they found 5 times a week to be too burdensome. So that's the paper associated with that piece of work. And the last study, and bringing us to the end of our talk today, is a study that was led by Susan Ebbels that I did in collaboration with her on the effectiveness of individualized morphosyntactic target identification and using explicit intervention using the shape coding system for children with DLD. But again, here, the part of the study that I'm really focusing on today is the fact that we looked at the impact of within session dosage. So we manipulated the within session dosage. So I'm assuming that everyone here is familiar with the shape coding system, but just to summarize, the intervention was developed by Susan Ebbels in Special School for Children with Severe DLD. It aims to teach grammar explicitly via visual coding, but as I've acknowledged earlier, there are a lot of implicit techniques embedded in there too. And it aims to help children with language disorders both produce and understand longer and more complex sentences. And it aims that they would make fewer grammatical errors in both their spoken and written language. So it assumes that children with DLD have difficulty learning language implicitly, that we know, and that they can learn language using explicit teaching, using their relatively stronger visual skills. Previous research has shown, it's been researched when delivered by clinicians trained in the system, in special schools, in language units, and so on. And it's been researched across the UK and Australia with children with severe DLD between 5 and 16 years. The sessions have varied 30 minutes usually for 1 or 2 sessions per week for up to 4 to 10 weeks. And a range of language structures have been explored, both comprehension and expression. So far, there's no obvious predictors of who can benefit over and above someone else. But importantly, from the context of what I'm talking about here, children receiving more teaching episodes did make more progress. In previous studies, the work tended to focus on just targeting just one structure, and they also tended to be for a set number of sessions. But really, if we want to maximize efficiency, we need to think about having highly individualized targets at just the right level, targeted for just the right length of time. So when a child reaches a predetermined criterion, using techniques that support learning, where we have a high number of teaching episodes per session. So that led us to this piece of work. And I'm not really going to speak about the feasibility aspect, because this was part of a much larger piece of work, except that we were looking at the feasibility of delivering 40 teaching episodes per session. So we wanted to see how doable is that. And we wanted to look at the effectiveness of the intervention in terms of progress overall and what children maintained. So for different children, and with varying numbers of teaching episodes per session. So we had 8 participants with DLD. The intervention was 30 minutes per week for 20 weeks, so it was 10 hours. We had individually identified production targets, and we used a multiple baseline design where each target had at least 3 baseline tests. So we were testing, for example, past tense. We were testing that target at least over a period of 3 weeks, so that we could show if there was stability, that there was no growth. Children were not learning this target without our input. So we wanted to show that first. So every target had at least a minimum of 3 baseline tests. And then we engaged with weekly probe tests until a 90% criterion was reached. So that was our predetermined criterion. If somebody reached 90%, then that intervention target was stopped and a new target was introduced from baseline. We also did maintenance tests 2 weeks, 6 weeks and 14 weeks after intervention stops. You might remember in one of the studies that I alerted you to, it was in relation to word learning, we had 40% drop off 1 week later. So we felt it's very important to look at what the maintenance effects were. So the intervention dosage was given in 1-to-1 with in a single with one SLT constantly throughout the intervention, but we did have a second backup SLT in case of sickness or and so on, or other commitments. 2 targets were focused on per session. And so we were aiming for 40 teaching episodes. So we worked on the targets aiming for either 10, 20 or 30 doses or teaching episodes, but we also wanted to control for the overall session length and the overall number of teaching episodes. So for half the participants, the aim was 10 doses for one target and 30 doses for the other target, which totaled 40. And for the other half of the participants, each target was given 20 doses each. And then we swapped the allocation between the 2 school terms. So this is just showing that we had a very detailed protocol for the intervention techniques that would be used, the procedures, the order in which they were used, and the feedback hierarchy. So I'm not going to go through that in any detail, but just to highlight here, what was a teaching episode? A teaching episode, so in this study, included here steps 2B and 2C. So, and it could include some or all of the active ingredients techniques in any of those steps, so depending on the child's skill level and the stage of the intervention. So for the purposes of our analysis, we deemed an individual teaching episode to be complete when a child had correctly said the target structure. So regardless of the level of visual support provided by the templates or the level of feedback hierarchy needed to achieve it, but when the child had completed the structure, said the target structure correctly.
So Charlie, what we're going to do today is we're going to look at some shapes, we're going to make some sentences, and we're going to use some animals. Is that okay? Mm-hmm. Brilliant. Okay, so we're going to start off with talking about, so what goes in here? A who or a what. Then we've got
Is.
And then we can talk about something they are what they are doing. Brilliant. What about sometimes they might not be doing something? So that's what we're going to practice today.
Yeah.
Okay, so I might say Charlie is not standing up. I might say Charlie is not dancing. Charlie is not flying. Charlie is not eating. Can you make up some about me?
Okay.
So you can use a what doing,
Miss Cat.
or talk about what I'm like.
Not tall.
Yep, true, that was a fluffy, yep.
Miss Cat is not at home.
True.
Miss Cat is not at school.
Oh, good. Okay, another one.
Miss Cat is not the speech no more. You're fired.
So in terms of our results, does the number of teaching episodes per session matter? So as I said, each target received 10, 20 or 30 teaching episodes per session. So when we looked at the number of sessions, those who got 30 teaching episodes or 30 doses did better. So yes, it does matter. So in that those who got 30 doses made faster progress. However, if we look cumulatively at what happened, then there were no differences in the end results once they all got the same number of doses. So giving 30 teaching episodes or 30 doses made faster progress. It allowed us get there more efficiently. But if you are having constraints in how you can manage and the amount of time you have, the other children did get there, just not as quickly. So it again speaks to the fact that the cumulative dose matters most. The odds of a correct response increased 3.9% for each teaching episode, and targets that were achieved required between 40 and 60 teaching episodes, so which was 2 to 3 intervention sessions, which is quite short. And importantly, there was no significant decrease during the maintenance period. So to summarise, the scores following the intervention were higher than baseline. There was significant progress with the intervention based on cumulative teaching episodes was the most important, the key factor in terms of our quantitative dose. There was faster progress for one child in particular who had the most experience with the shape coding, and one child made no significant progress, and that was the child who would have had the poorest attention. The rate of progress obviously did vary with the target that was being worked on, but importantly, the total number of teaching episodes was key. So the distribution, how they were distributed across the sessions, again, was less important. We also rarely needed the feedback hierarchy, and progress was well maintained. So that's the paper that's associated with that work. So just to kind of summarize and bring things to a close, I realize we've given an awful lot of information here today, and to summarize, it's clear that all components matter in relation to both the quantitative and the qualitative active ingredients, and there's clearly an interaction between the two, and we have a lot more to learn. If I wanted to leave you with a couple of key messages, I would say be intentional and aware of the active ingredients that you are using. Define what it is you consider to be a teaching episode and manage your within session dose, really aiming high so that we can try to optimize efficiency and effectiveness. In addition to the fact that we have a lot more to learn, the intervention literature is complicated by the fact that we don't have an agreed regulated practice on what we call things. So one person's cueing is another person's prompting or scaffolding. The participants in our research studies don't always represent those that are on your caseloads. And, we need to really look at that very carefully. And our outcome measures are so variable in what they measure and in the timing of when they're administered. It's very difficult for us to synthesize our findings in a way that really moves the field of SLT forward. So with that in mind, we formed the TICLED group, the Intervention Consensus for Language Disorder group. And the group was convened by Professor Cristina McKean and I, and we have project leaders from Ireland, the UK, the US, Australia, Finland, Austria, Croatia, lots of different countries. And at the end of 2023, we received large funding to try and ensure that interventions that support language and communication deliver maximum benefit for children with or at risk for DLD. So to do this, we aim to develop a set of internationally accepted reporting guidelines that will specify the intervention characteristics. It will specify, we will develop a taxonomy of what all of the active ingredients that we deem to be important, and that we agree a regulated practice on how we define those. We'll also specify the participant characteristics. We're very cognizant that we need to make sure that all groups are included. Many research studies like participants to be very clean and uncomplicated. They often actively exclude bilingual children, for example. So we want to specify the participant characteristics and also the outcomes in children's oral language intervention studies so that the outcomes are meaningful to the people with DLD and their families. So our aim is that this work will reflect the perspectives of all relevant stakeholders, and then will enable us to translate research into practice through the development of a comprehensive training program, which we hope will be embedded into all pre-registration SLT courses, so that we won't end up in this situation again. So to do this work and really move the field of SLT forward, we need you, the voices of SLTs, people with DLD and their families will be central to this work. And so watch out for our recruitment calls. You can follow us on Instagram, Blue Sky, and this is the link to our website. So this is something we can only achieve with input from many clinicians across the world. So we hope that you will work with us to do this so that we can move the field of SLT forward. Thank you.
Well, what can I say? That has been the most amazing hour and a half. A wonderful opportunity to have time with both Pauline and Cristina. Thank you so much. So interesting and so much learning there for all of us. I'm sure everybody has found it as intriguing and fascinating as I have. So thank you. We had loads of questions before the session. We've also had lots of questions now. Our time is running out, but if we could go to the previous slide, please, Hannah, that would be wonderful. Thank you. Oh, okay, don't worry. We're on the question slide, but the question slide is not there now, but that's okay. We are dealing with questions at the moment, so we could just go to the previous slide if that's okay. Thank you. I'm going to ask just a couple of questions based on the time restrictions that we have, but there is so much interest in all of this. I would say, how would you recommend services and speech and language therapists change models of service delivery when the dosage is not evidence-based? And, you know, thinking about legal implications, working with different service models and so on. Could you give us some advice about that, please? And the use of homework as well. So it's a broad-ranging topic, I know, but
well, I suppose one of the key messages, the within session dose, that is the one thing that is within your control as a clinician. You know, so we can't control if we're in an area that has the 6-week block. There's nothing you can do about that, only to advocate and, you know, fight against it and talk about the evidence, and that we keep, you know, promoting the fact that it isn't enough and the unethical nature of it. It's an economics-based decision, not an evidence-based one. So I think that's the first point. But I think what is within our control is within session dose, and being intentional about that. And I think even though the dosage terminology is very medically orientated, and we may well move away from it, I think it has been a useful place for us to start and to really think about, and to move away from the fact that we're not just sitting there, you know, playing with a child, like that there's a lot going on that people don't see if they don't understand what's happening. And so I think we need to be very intentional about the techniques we're using, the order in which we're using them, as we said, our method of instruction. And there are many more very important active ingredients, like the rapport and the relationship that we build, and we're not at all in any way ignoring that, but just the focus of that's a whole other talk. The focus of today really, I suppose, was on those kind of within the kind of very much technique focused areas. And I think the other thing I think is we can use parents and the wider community more. I mean, both Cristina and I are advocates for very much a public health model and a public health approach to the delivery of speech and language services, particularly for people living in social disadvantage. I think for children with more severe DLD, I think we need to coach very clearly. So I believe a lot in Anne Kaiser's work on using the teach, model, coach, review. And I think as therapists, we model very well often, but I'm not sure that we always coach. And I often think that we need to be taught actually more in our undergraduate training programs how to coach parents. But I suppose tailoring back from that, if you're not clear yourself on your active ingredients, your techniques, your teaching episode, then you can't really coach somebody else adequately enough in them. But I think we can certainly use the broader community to help as well with our dosage.
Thank you. Really interesting about the value of coaching and that tacit, you know, we have that tacit sort of understanding that we all know how to coach, but actually, do we? I think that's a really good point. Thank you so much. Cristina, do you want to add anything to that?
I think Pauline's covered most things. I think one thing I would say, I noticed a question linked to this about EHCPs and things like that. I think what's another take-home message here is really we can probably be quite flexible with how we schedule what we're providing, as long as we're giving enough. And I think you know, once a week versus twice a week versus, you know, I think there isn't evidence to say one is better than the other, and there is evidence actually of sort of twice weekly and works as long as there's enough of the active ingredients in there, and little and often works as long as the right active ingredients are in there. So I think that gives us the potential to be a bit more flexible, but but we absolutely do need to keep the in-session dosage high, and we also absolutely need to be measuring the change in the young people. So our intervention should be about meeting criteria and us looking very, very closely at when children are actually achieving the goals that we're aiming for, and also, as Pauline said, taking breaks and rechecking whether or not they've retained the learning. So I think we should be adding into our models these careful review of what's working for an individual child and what isn't working for an individual child. And homework, I think, just very briefly, obviously that's an issue because it's a potential to widen inequalities, isn't it, if families are not in a position to do the homework. And also homework's pointless and work if people are not actually using the active ingredients themselves. So I think we need to think really, really carefully about what we're asking of parents and where we get the support for individual children to have extra help. It obviously is a good idea if people are really using the right active ingredients, but if not, then it is a waste of everybody's time and sometimes tears if we are asking things of parents that aren't going to work.
Yeah, thank you so much. Fascinating. So much you've discovered so much and shared so much to help us move our learning forward, and we look forward to finding out more from you as you develop the field for us all. So thank you so much. And we are hoping that we will be able to have a special edition of IJLCD looking at dosage and active ingredients, moving forward with both of you involved as guest editors. We hope as we move forward, be exciting across populations and domains as well. So that will be something to look forward to. But thank you so much. Really, really fabulous annual lecture. I'll just give you a little clap. And could we please move on then to the next slide, Hannah? Thank you. Yeah, so we are always looking for peer reviewers for the journal. So this is just a little call out to you if you're a specialist or a researcher in a clinical area and you would be interested in getting involved. Check out Wiley's resources on peer reviewing. The link will go into the chat, but there's the link there also. And contact Claire or myself. Claire is the editor-in-chief focused on adults, and I am for pediatrics. And we've got a fabulous group of associate editors who work with us as well, including Mark, who's been awarding the prize today. So thank you for that. And it just remains for me to ask you to please click on the link in the next slide to complete the evaluation before you leave. And thank you again, all of you, for being here. I think you'll agree, a fantastic opportunity to have special time with Pauline and Cristina. So thank you all for your involvement. It's been a great hour and a half. Thank you. We could ask another question whilst we're waiting, whilst other people are filling in their evaluations. Claire, would you like to ask a question?
Thanks, Jill. Sorry, I've got a bit of a cold, which is not a good thing for a speech and language therapist at an event like this. We had lots of questions about how to apply some of your suggestions around dosage and active ingredients for children who have diagnoses other than DLD. Now, you touched on a little bit of that and gave us some lovely examples of the children with Down syndrome, but people were asking in the questions about older children or people with other difficulties, sensory difficulties, bilingual children, children who have come from a refugee background, AAC users. There were a raft of questions, and just wondered if you had any literature that you could perhaps point people to give some guidance on how to apply some of the thinking around active ingredients and effectiveness with other groups of children and other populations.
That's a tricky one. Sure, I do know there's work that's been completed in speech sound disorders, so I think there's work out there for people to look at in that space. But I think we obviously haven't done a systematic review across all of these different client groups, but maybe that's something we can look at in our special issue. But I don't know that it's been looked at rigorously across many different domains, and it's an area of research that we need to do more work in. I think the Tickle project, one of the reasons that I wanted to get involved and make the Tickle project happen with Pauline is to think about getting us to report the participant characteristics much more carefully, so that we can start to say in more detail, oh, it works better for older children, or the lovely work that Pauline did to show that it works better for children at a particular level of language development. So looking at how Dosage interacts with individual differences of our participants, and we don't have that information, I would say, currently. Yeah, I think specifically talking about BEST, for example, we know that it works in languages other than English, so we can answer that. But you know, I think we need to find out more. Pauline, do you want to say some more?
I think certainly from the Down syndrome literature point of view, there is enough literature out there saying that the dosages that are commonly reported are far too low, and that we are not meeting the target or anywhere near it. So I can certainly speak to the literature for people with intellectual disability and people with Down syndrome, and that we need a very much an individualized approach. I think, and also more of the literature, if we think about method of instruction, more of the literature is around that certainly we should absolutely be doing that with older children. And we should use more of an explicit methodology when we're working with older children. But I think even though we don't have all of the literature and the nuances, I think a lot of the principles about what we have raised today would apply across, and a lot of them are quite intuitive. And if we think about models of language learning and the theory behind language learning, a lot of what we say today, I think we would expect it, I could say, that we would expect that it would be applicable to these other groups. But of course, we would have to empirically, you know, examine that.
Thank you. Thank you very much. That's, yeah, interesting. More research needed. All those potential PhD researchers out there, you know who to come to. But anyway, it just remains for me to do a final thank you. It was a fabulous couple of hours. Really enjoyed it. Very valuable. And thanks to everybody for coming. Many thanks to Pauline and Cristina again.